Okay. Good morning. My name is Javier Alejandro Palafox Salinas. I'm fourth-year resident in the radiology department at the University Hospital, Dr. Jose Eleuterio Gonzalez. In this day, we are going to see a 67 years old male patient. Is the case currently in this case he present with a non-amnesic neurocognitive disorder characterized by progressive aphasia and irritability. The Mini-Mental score was 28 over 30 points, and the MRI only refers to change due to chronic vasculopathy and cortical subcortical atrophy. Here we have a study of PET-CT with 18F FDG with brain protocol, and in this imaging we show an abnormal hypometabolic pattern in the left temporal lobe as well as in the left occipital lobe. We saw a hypocaptation, less captation in these zones of the radio tracker. Likewise, an abnormal zone of glycolytic hypermetabolism is observed in the gastroesophageal junction with extension to the cardiac of the stomach. 1 week later, we take a biopsy in this region, and we discovered the biopsy confirms the diagnosis of moderately differentiated adenocarcinoma, which was treated with surgery. Okay, the final diagnosis in this patient was paraneoplastic neurological syndrome. This is important because the paraneoplastic neurological syndrome are a heterogeneous group of disease in patients with a cancer that is caused by mechanisms other than the side effects of the cancer therapy, the infiltration of the tumor in the nerves, spinal roots, or nutritional deficits. The neurological alterations are detected at most 1 year prior to the diagnosis of the primary tumor. Therefore, it is important to take into account this type of diagnosis in order to locate this tumor and avoid the progression of the neurological symptoms. The paraneoplastic neurological syndromes are associated with small cell lung cancer, breast cancer, and cancer of gynecological origin. However, few cases have been reported in which they are associated with the gastric carcinomas. This type of alteration represents less than 1% of the cases, which is why they are generally undiagnosed. In the left side, this table represents the neurological alteration in this alteration of these syndromes at the level of the central nervous system, the peripheral nervous system, muscle, and others. And in the right side, this represents the prevalence of the association of the neurological paraneoplastic syndromes with different types of tumor. As we see in this table, we see that the small lung cell cancer is the most common. The second one is the ovarian cancer, and the third one is the breast cancer. Also, here we see that the esophagus and gastric cancers only represents 1.8% of these type of associations. This is another example of a patient with a short-term memory loss and disorientation, worsened progressively, and his mini-mental state examination score was 12 over 30. In the left side, we have a MRI of the brain. This is a FLAIR sequence. Here we see hyperintensities in the bilateral hippocampi and left amyloidoid body. The diagnosis was limbic encephalitis. They treat the patient, but the symptoms persist after 1 week. They take endoscopy. In the endoscopy disclosed a poorly differentiated adenocarcinoma with neuroendocrine features in the gray curvature of the gastric atrium. 3 weeks after the surgery, they take another MRI, and in this imaging is another flare sequence, and we see the disappearance of the hyperintensities and in the bilateral hippocampi. Also, neurological status improved gradually after the surgery. We have to remember that in these patients, when we take out the primary tumor, the neurological symptoms will disappear or almost disappear. Because this is important to find the primary tumor. In conclusion, as was evident in the previously reported case of gastric carcinoma with paraneoplastic neurological syndrome, early detection is the key to improving oncological and neurological outcomes. Therefore, careful and rapid examination are necessary when such neurological disorders are observed. And that's all. Any question? Thank you very much.
My patient is a female, 55 years old, with breast implants 18 years ago, refers hardening in right breast 1 week ago. We are seeing bilateral craniocaudal views of mammography. Both breasts have great areas of fibroglandular density. Bilateral implants are observed in a retropectoral position with altered morphology, folds in their contours, and pericapsular calcification. In this slide, we have bilateral mediolateral oblique views. We can see the same findings, plus axillary regions with lymph nodes of preserved morphology. By ultrasound, breast implants are observed anechoic, observing linear echogenic image, mobile inside both implants, as well as per-implant free fluid, suggestive of intracapsular rupture. We have 2 types of breast implant ruptures. It can be intracapsular or extracapsular. Intracapsular when it's confined by the surrounding fibrous capsule, or extracapsular when silicone freely extravasate. A fibrous scars form around the implant after implantation of the breast implant. In the intracapsular rupture, the silicone does not freely extravasate because the fibrous capsule formed by the breast. Only the shell of the implant is broken. Intracapsular rupture is best seen on MRI. We can detect an extracapsular rupture on clinical examination or mammography because the change on the implant contour. The mammography is not the best option to detect implant rupture. Detection of intracapsular rupture are almost impossible on mammography. Ultrasound may demonstrate a snowstorm appearance of an extracapsular rupture or the steep leather sign of an intracapsular rupture. The snowstorm sign, green arrows, describes the dirty shadowing appearance of extracapsular free silicone. On breast ultrasound imaging represents the presence of free silicone droplets mixed with breast tissue, giving a characteristic heterogeneous echogenic appearance. This is the step leather sign, consisting of the horizontal line visible in the slide, green arrows, is the ultrasonographic equivalent of the subcapsular line sign. The horizontal lines represent the collapse shell of the silicone implant, which is floating in the silicone located but with an external to the rupture shell, but still contained within the fibrous capsule. The MRI is most sensitive for detection of implant rupture. The rupture, it can be diagnosed with a simple study, and the Linguini signs in this example indicate by the red arrow represents wavy lines made the cover of the collapsing plant contained within the capsule. And this is all.
Okay, good morning. I am Dr. Adiel Medrano, currently fourth-year radiology trainee at the Medical Imaging Department of University Hospital, Dr. Jose Luterio Gonzalez. And today I'm going to show you this case. Okay, this is a 32-year-old male patient with a history of soft tissue tumor in the right hand since he was 3 years old, referring areas of dysesthesia and anesthesia of the median nerve territory. He refers the tumor started in the radial aspect of the palm region of the right hand, and posteriorly it extended distally towards the third finger during the first years, and later extended proximally towards the central region of the palm and wrist and the distal third of the forearm, as we see here in this image. At the age of 9 years, he underwent her first surgical intervention with excision of approximately 70% of the tumor and reconstruction with C-plasty, as we see here, and a skin autograft in the proximal third of ulnar aspect of the third finger. It's this one. The histopathological result of the biopsy was not conclusive, describing the tissue as a peripheral nerve with normal axon fascicles surrounded by fibroadipose tissue. We see here the axons surrounded by fibroadipose tissue here. Years after the procedure, the lesion reappeared, presenting a rapid growth, again with extension to the third finger, the tenar eminence, and the central region of the palm, now with increase of volume of the radial aspect of the second finger and the dorsum of the hand between the second and third metacarpal bones, being this his actual chief complaint. Okay, and the physical examination, he presented scars, as we see in the image, in the palmar aspect of the right hand, the third finger, and distal third of the forearm, a soft fixed and non-painful mass with palpable and volar side of the hand. And another notorious finding was, as we see here, the loss of volume of the tenar eminence due to atrophy of the opponent's pollicis muscle. During the motor test, there was inability to achieve an adequate opposition of the thumb with the fifth finger. During the sensory test with Siemens-Weinstein monofilament, the patient referred paresthesia and anesthesia in the distal territories of the median nerve. The sign of Tinel was positive, however, the patient denied carpal tunnel compression symptomatology, and the Fallen test was negative. An MRI of the right hand was performed. In this T1 axial plane image, it's not possible to delimit the medial nerve. Some axonal fascicles can be identified separately and intercalated within the fibroadipose tissue, as we see here. And proximal to the carpal tunnel, there's abundant amount of fibroadipose tissue surrounding the deep and superficial flexor tendons of the fingers, as we see here in the red arrow. Although at the level of the carpal tunnel, deep to the flexor retinaculum, this is this one, there is a very little amount of fibroadipose tissue that it shouldn't be found on this topography. The greater amount of fibroadipose tissue is observed superficially to the flexor retinaculum in the topography of the palmar cutaneous nerve, which is a branch of median nerve also. Distal to the carpal tunnel, here, note the lesser amount of fibroadipose component superficial to the palmar fascia, that is this one. And how this tissue takes a deep predominance following the territory of median nerve with infiltration of the interosseous muscles between the second and third metacarpal bones. This is the interosseous muscles, and see how it's infiltrated by fibroadipose tissue here. And also in this image with the red arrow, we can see the fibroadipose tissue infiltrating all the interosseous muscles. This is the second and the third metacarpal bones. Observe the distal continuity of the fiber adipose tissue toward the third and second finger following the territory of the median nerve branches. Note there's no abnormality of the flexor tendon in all his weight in the third finger, and there's no abnormality of the sheaths and the pulleys on the palmar aspect of the finger. This is the flexor tendon, and all the sheaths and pulleys are preserved. And this image, there's no bone giantism on the affected fingers, the second and third fingers in this case. In these T1 coronal images, we can see the deformity that exists with infiltration of fiber adipose tissue within the interosseous muscles. Between the second and third metacarpal bones, there's no deformity or giantism of the carpal, metacarpal, and phalanges. And also we can see the distal continuity of the tumor towards the second and third finger in these coronal images. As we see here in these coronal steer and axial T1 images, there's no inflammatory changes or edema, and we can see exostosis at the middle phalange of the third finger. Sorry. Here in the red arrow. So the diagnosis was a lipofibromatous hamartoma of the median nerve, also called LFH. So lipofibromatous hamartoma is a rare and benign tumor that affects peripheral nerves. Approximately 180 cases have been reported. This tumor characterizes by hypertrophy and infiltration of perineurium and epineurum by mature fatty tissue and fibroblasts that surround and separate the axonal fascicles, giving the nerve an onion bulb appearance. It's considered to be congenital since it manifests itself in the first years of life. It was first described by Mason in 1953, and a lot of terms have been proposed in literature to describe it, such as neurofibrolipoma, perineurolipoma, lipofibroma, or neurolipoma. The pathogenesis of this tumor is unknown, and there does not appear to be hereditary predisposition. It may be associated with other abnormalities such as fatty, bone, and vascular tumors. It's more common in males with higher incidence during childhood. It has a predilection for the upper extremity in the 65 to 80%, affecting the median nerve in the 80% of the cases. It's usually asymptomatic in most cases, but some patients refer carpal tunnel syndrome due compression of the nerve by the flexor retinaculum and manifesting during the youth or adulthood. The MRI findings in LFH are considered pathognomonic. It is common in these patients to present exostosis of the territory of the median nerve and is not associated with inflammatory changes or edema as we saw in the images in our case. The ultrasound is helpful, but definitive diagnosis is obtained by histopathologically. The main differential diagnosis of LFH are lipoma, neuroma after trauma, vascular malformations, and ganglionic cyst. There's no definitive treatment for LFH, but when there is a symptoms of compression of the carpal tunnel, the surgical decompression is decided. Due to its complexity, complex architecture, the surgical approach is all a challenge, since resection without neurological damage isn't possible. The mere decompression of the nerve and reduction of the fibroadipose layer that surrounds it has shown more positive results. And that's it on my references. Any question? No? Thank you.